Hello everyone. So in this video, we are going to discuss about the certain questions. That is, four of the questions are discussing. So in the skin disorders, we are going to discuss about the Mongolian spot, and in the eye disorders, we are going to discuss about the congenital and developmental cataract, and also in the disorders related to ear, we are going to learn about the management of um the otitis media, and also about the procedure like a laryngoscope. So these are the four questions we are going to discuss in this video. So first, about the congenital and developmental cataract. The congenital cataract, that is if there is any disturbances in the normal growth of lens, which occurs before birth, that results in the formation of congenital cataract. Uh, and these disturbances which occurs before birth, because of that, the opacity is limited to either fetal or the embryonic nucleus only. And another is the developmental cataract, which may occur from the infancy to adolescence, and opacities which may involve infantile or adult nucleus and deeper parts or cortex of the deeper part of the cortex or capsule. So these are about the congenital cataract and developmental cataract. Then what is the etiology behind the cataract? That is, in the one third of the cases, the etiology is idiopathy. That is, there is no known cause for the development of the congenital and developmental cataract. And in the case of the and another one third of the cases, it is due to hereditary, that is autosomal dominant cataract, chromosomal disorders like Down syndrome, skeletal disorders like Stickler syndrome, and the cerebro-oculofacial syndrome and Lowe syndrome. In these cases, that is about one third of cases is due to hereditary. And the maternal factors like malnutrition during the pregnancy, infections like rubella, toxoplasmosis, and cytomegalovirus infection, and the drug ingestion, example corticosteroid, and radiation during pregnancy. These all results in the causation of the congenital and developmental cataract also. Then fetal or the infantile factors like hypoxia, if there is any birth trauma, and metabolic disorders like galactosemia, then also neonatal hypoglycemia, which also results in the etiology, which also results in the formation of the cataract in the that is congenital and developmental cataract. So that is all about the etiology of the cataract in the childhood. Then about the differential diagnosis of the cataract, retinoblastoma, retinopathy of the prematurity, and the persistent hyperplastic primary vitreous is the differential diagnosis for the congenital or the developmental cataract. Then about the management of the cataract, that is clinical investigative workup should be required. That is, it include density and morphology of the cataract, then assessment of the visual function, which is difficult in the infants and small children, then associated ocular defects like microphthalmia and glaucoma, etc. should be looked for. Then about the laboratory investigation, this is all about the examination part, that is clinical examination part. Then about the laboratory investigation, we have to we have to look for the intrauterine infections like torch infections and galactosemia, Lowe syndrome, and hypoglycemia. And then about the treatment or surgery, so we discuss about the etiology, differential diagnosis, and the clinical investigative workup for the congenital cataract. Then about the treatment, that is mostly the surgery is the treatment of choice, that is partial cataracts and small central cataracts which are visually insignificant, they can safely be ignored and observed, or which may need surgical treatment. Bilateral dense cataracts are to be removed within 6 weeks after birth, and second eye to be operated within few days of the first day. Then unilateral dense cataract will be there, that have poor prognosis and removed as early as possible to prevent the amblyopia. So these are the treatment, that is surgery is the mainstay of treatment in the case of the congenital cataract. Then prognostic factors are the density of the cataract, then unilateral, the bilateral, the time of the presentation, associated ocular defects, and associated systemic defects, which are the prognostic factor for the congenital cataract. So that is all about the congenital or developmental cataract. So today's another short note is regarding the skin disorders, that is Mongolian spot, that is asked as a short note. So the Mongolian spot, that is the common form of cutaneous hyperpigmentation that is seen in the neonates, and which occurs in about 46% of cases. And the underlying pathology behind the formation of Mongolian spot is that there will be dermal melanocytosis, and the clinical features of this Mongolian spot, which include the slate gray macular pigmentation present at birth. That is, at the time of birth, there will be slate gray macular pigmentation is present. And the usual or common site are the buttocks, mid-sacral area, back, shoulders, and extremities. And the differential diagnosis for this, the macular pigmentation are the bruise and nevus of aorta, that is blue-gray round eyes. Then treatment is not needed in most of the cases, and it is usually harmless and often fade before adulthood. So it is only present at the time of the neonate and the early childhood, and before the adulthood, it will be disappear. That is the prognosis. Then rarely widespread Mongolian spots associated with the Haller syndrome and a mixed malformation. So that is all regarding the Mongolian spot. That is gray macular pigmentation present at the time of birth is the characteristic feature of the Mongolian spot. And it's usually harmless and often fade before the adulthood. Another short note in this video is about the ear disorders, that is acute otitis media. So we have to first, that is acute otitis media is asked as a short note or short essay. And the management of the acute otitis media is one of the short note which is usually asked in our university exam. So about the acute otitis media, the definition of the acute otitis media is that if there is any presence of fluid in the middle ear with accompanying symptoms and signs of otalgia, fever, autoria, and bulging red or yellow tympanic membrane. As the name indicates, acute otitis media. The media, which means middle ear is affected, there will be inflammation and fluid collection is that's acute onset. So the presence of fluid in the middle ear with accompanying symptoms and signs of otalgia, fever, autoria, and bulging red or yellow tympanic membrane. That is the definition of the acute otitis media. And the otitis media with the effusion, that is without the symptoms, it is called the otitis media with the effusion. That is only if there is any presence of the fluid in the middle ear without the signs and symptoms, it is called the otitis media with effusion, where antimicrobial therapy which may be deferred in that cases. And the recurrent otitis media for the greater than or equal to 3 episodes in 6 months or greater than or equal to 4 episodes in 1 year. That is called the recurrent otitis media. That is greater than or equal to 3 episodes in 6 months or greater than or equal to 4 months in 1 year is called the recurrence of this acute otitis media. Then about the predisposing factors for the acute otitis media, these are the, if the eustachian tube is shorter, more horizontal in the kids, that is usually in the kids, the eustachian tube is shorter and more horizontal and surrounded by the lymphoid follicle. So more, so that the kids are more vulnerable to infection because of the structural characteristic. Then about the bottle feeding, that is if the child is on the bottle feeding, that generates strong negative pressure that increases the passage of milk into the eustachian tube that results in the formation of the acute otitis media. Then the more viral infection is happen in the case of kids, therefore downregulates the immune system. Therefore, there will be that is also a predisposing factor for the development of the acute otitis media. Then also the passive smoking is a predisposing factor. Then cleft palate, Down syndrome, and immunocompromised kids also have the high predisposition risk for the development of the acute otitis media. Then also allergens of the allergic rhinitis also a predisposing factor for the development of the acute otitis media. That's so that is all about the predisposing factor, that is shorter and horizontal eustachian tube in the kids, then bottle feeding, viral infections, and passive smoking, cleft palate down and immunocompromised kids, and allergens in the allergic rhinitis. These are the predisposing factors for the causation of the acute otitis media. Then about the etiology, the most commonly organism involved is the Streptococcus pneumoniae. That is about in the 50% of cases, the most common organism involved is the Streptococcus pneumoniae. And in about 30% of cases that is caused by the Haemophilus influenzae, and in the 1.5% of cases that is caused by the Moraxella catarrhalis. So the most common is Streptococcus pneumoniae, and the second important is the Haemophilus influenzae, and the third is the Moraxella catarrhalis. Then about the clinical features, it is the main clinical features in the acute otitis media, there will be pain is present, then discomfort in the ears, then have because of this infection, that is because of this collection of the fluid in the ear, there will be infection that results in the fever and irritability. If severe, that results in the because of this that is if there is severity, there will be rupture of the tympanic membrane and which causes the otorrhea, that is the discharge from the ear. Only if the tympanic membrane is ruptured, only that causes the otorrhea. Then, so these are the clinical features in the case of the acute otitis media. Then about the investigation, we have to take the ear discharge if there is present, and it is sent for the culture sensitivity and gram stain, and to find out the organism responsible. And otoscope is also used to find out if the tympanic membrane rupturing or another signs. Then also hearing test to detect any hearing loss, that is conductive hearing loss, have to be determined by the hearing test using the tuning fork test, and also by the another methods also. Then we have also used tympanometry. Usually it is not required, but in certain case we have to use tympanometry. So these are the investigations. So about the treatment, the principles of treatment is classify whether it is acute otitis media or otitis media with effusion only. That is, without symptom of this is called otitis media with effusion. So classify whether it is acute otitis media or otitis media with effusion. That is, in the otitis media effusion, we do not have to give the antimicrobials. So, otitis media with effusion does not need antimicrobials only after 3 months of persistence. Then, antibiotic prophylaxis for the recurrent acute otitis media will be given. Then about the, so that is the principle behind the treatment of the acute otitis media. Then about the antibiotics, first line is amoxicillin 100 milligram per kilogram per day or co-amoxiclav, or cefuroxime or cefpodoxime or ceftriaxone, that is second or third generation cephalosporins. The systemic, that is usually orally, as ear drops do not disinfect the middle ear. So usually systemics are used, but the ear drops do not disinfect the middle ear. Then about the duration, we have to give this antibiotic for less than 2. If the child is less than 2 years with the complication, we have to give for the 10 to 14 days course. Then if the child is greater than 2 years, we have to give 5 to 7 days. Then for the pain relief, we have to give the paracetamol or ibuprofen, local anesthetic eardrops, if no ruptured eardrum. Then avoid swimming in, that is advise the child to avoid swimming. The nasal decongestant drops improve the drainage by the eustachian tube. So these are the pain relievers in the case of the acute otitis media. Then about the surgery, if there is if surgery is done only with if there is a bulging drum or impending intracranial complication will be there, and it is rarely needed. And the complications of the acute otitis media, which are usually asked, like intratemporal complications, then hearing impairment will be the tympanic membrane perforation because of this bulging, and there will be labyrinthitis because of this transmission of this infection to the inner ear, and then also there will be facial paralysis because of the compression to the facial nerve by this increased pressure in the middle ear. Then about the intracranial complications are there, like intracranial abscess and brain abscess will be there, and meningitis, and also extradural abscesses. So these are the complications following the acute otitis media. Then about the prevention, how will you prevent the acute otitis media from developing? We have to avoid the predisposing factors, like bottle feeding we should be avoided. So we have to give the breastfeeding, prevention of cold and fever, avoid exposure to passive smoking, pneumococcal vaccine should be taken because important organism causing is Streptococcus pneumoniae. So if the pneumococcal vaccine is given, it should be a protective mechanism against the bacteria. Then influenza vaccine should be taken, and also we have to concern about the emerging bacterial resistance. So that is all about um, the acute otitis media as in the ENT disorders in the childhood. Then another short note is regarding the laryngoscope. So it is laryngoscope is usually required for the endotracheal intubation process, and it is also used in indirect laryngoscopy to visualize the larynx and vocal cords. So in the pediatrics, we are used laryngoscope for the endotracheal intubation. Also, it is used in indirect laryngoscopy to visualize the larynx and vocal cords. So uh, uh, this is the laryngoscope. And the parts of the laryngoscope include handle, the blades 0001 for preterm, and term newborns, straight blade used in newborns, and curved blade which is in the older children and adults. Then bulb, that is yellow and white light, detachable or fixed will be the, then extra battery should always be kept ready. So that is all regarding the parts of the laryngoscope. Then about uh, the cleaning the laryngoscope. Detach the parts and clean with the soap and water with the brush to remove dirt, and then clean under running tap water. So that is the cleaning method for the laryngoscope. Chemical disinfection with the Sidex can be done for the 4 hours. Then how to hold the laryngoscope? Laryngoscope is always held in the left hand position, irrespective of whether the person is right-handed or left. So always the person should hold the laryngoscope in the left hand. Then these are the landmark for the placement of the laryngoscope that is tongue, vallecula, and epiglottis. According to that, we can insert this laryngoscope and it is used for the visualization of larynx is the indirect laryngoscopy, and also it is used for the endotracheal intubation. Then method of the intubation, the stabilized body's head, open baby's mouth and insert scope till the tip in vallecula, lift the blade and visualize anatomical landmarks and insert the tube, that is endotracheal tube is insert the stabilized tube with the right hand, then shift to left hand, then attach bag and ventilator. This is the method of intubation using this laryngoscope. So uh, if the endotracheal tube is adequately placed or checking placement, we have to look for the improvement in the heart rate and SpO2, audible breath sounds in axilla, no gastric distension, vapor contention, symmetrical movement of chest with each breath, and carbon dioxide detectors, that is calorimetric and capnography. So that is all regarding the checking the placement of endotracheal tube with the help of the laryngoscope. That is all regarding the laryngoscope. So thank you.